mic? Somebody? Questions, comments? Anything you'd like to share with the group about what you're sitting with right now and what you're taking with you?
Questions? Comments? Yes, Miss Bai.
I'm Bai Bagasao with UNAIDS. Thank you, Doctor, for your very, I think, moving presentation and interaction. I was just reminded of the Aesop's fable that I was reading to my grandson yesterday as part of his schoolwork, and it was about the boastful traveler, and the moral of the story was actions speak louder than words. And for me, I think your over 20 years of practice has actually touched me personally, because it's not so much words. You are actually speaking from your experience, and the actions, as you said, you know, the goals, as well as the destinations that maybe some of the patients that and people you have touched, including those you work with, comes out very well. My take-home message is that comprehensive is not necessarily equal to integrative. And for me, this is my biggest learning. It's the integrative approach to harm reduction. So thank you very much.
Thank you, Miss Bai.
Good afternoon, Doctor. You asked what I was thinking right now. As a grandmother, I'm thinking about at the risk of exposing our social problem to a foreigner. I'm thinking right now of the street children we have along our main thoroughfares who are openly using rugbies or whatever. And I was wondering who, or if the authorities cannot do anything about them. Well, that is a question for me. Thank you.
There's someone over here.
My name is Juno Pigarito. I'm from Cebu City, representing people who inject drugs. And I'm sorry for the English, I'm not so good. I'm just like, it's not really a question, but I just like to thank all the program, like the harm reduction program. It really helps a lot of clients. Like in Cebu City, we struggle a lot of injector drug users there. Right now, there are, I think, 5,000 population of drug injecting, and that's why we have a really problem in a disease called HIV, because the needle and syringe program has stopped and the virus has spread. So right now, I would like to say, because there's a lot of people here, maybe they can help us. Also with the drug board, dangerous drug board, so that they're also aware that it's really the NoBox syringe program is really effective, so that in Cebu City, people who inject drugs there are HIV rising. So we really need the needle and syringe program to protect them. That's all. Thank you, and thank you, sir, doctor.
Thank you. I think there are some people from the Dangerous Drug Board who agree with you, actually, who are here.
Hi, good afternoon, doctor. It's a pleasure to be here with you. My question is um, about neurolinguistic programming. I find it related to its principles, to its notion that wherein you accentuate the positive. So I'd like to know the difference of your theory to NLP. Thank you.
What I've tried to do is develop an overarching model identifying these 7 therapeutic tasks, but that within each of those tasks can be accomplished in many different ways, depending upon your personal training and therapeutic interests, and depending on the particular person that you're working with. So that, for example, with embracing ambivalence, motivational interviewing has one way of bringing the ambivalence into the room and talking with both sides of the ambivalence. There's another technique we call the decisional balance, which is more paper and pencil, writing down pros and cons of the current behavior and the new behavior that one is considering doing. My approach also is to actually have a dialogue with both sides, you know, the part of the person that wants to change and the part that wants to stay the same. So the point that I'm making is that there are many ways for people to achieve these different therapeutic tasks depending upon your therapeutic approach. If you take a look at my book, what you'll see is that I've gathered together 10 therapy cases that are done by different practitioners from different orientations with different patients who have different needs. I personally know a little bit about NLP, but it seems to me that if NLP is about supporting people in changing beliefs and you know, challenging old entrenched patterns, you could become a harm reduction NLP practitioner. We have people who are Gestalt harm reduction practitioners or CBT harm reduction practitioners. So I think that the model gives room for people to work from within their approach that best suits them and their patient. Anyone in the room feeling a little disturbed or
Yes, doctor. I'm Rio, by the way. I'm a guidance counselor at De La Salle Health Sciences in Dasmariñas. I was about to, yeah, I'm a little bit bothered about this thing because what's going on in my mind right now is that while the topic that we're discussing right now aims to reduce harm on the person who's using drugs, how would this address, you know, the harm that these people cause in the society? Because here in the Philippines, the reason why drug use is being criminalized is because of drug-related crimes that are going on. So without drugs, there would be less crime. That's as far as, you know, what the universal thought here in the Philippines is. But with this approach, I think, yeah, it somehow it's for us being more humane to people, or to understand further what these people who's using drugs are undergoing through, and how can we help them. But on the other side, isn't it that we're trying to tolerate them to use or to have them use drugs in a supervised way, as you told us a while ago? And another thing that's bothering me is that drugs here is, you know, is also some kind of a business, although in the illegal side. And would this also, you know, these drug lords would also be more, what do you call this, motivated to sell because there is an organization that supports this kind of thing. That's it. Thank you.
Well, I think that one thing I might take issue with you or raise as a question is drug use automatically correlated with crime? Or are those two different things? And what are the factors that actually contribute to a drug user engaging in crime? And how much of that has to do with our attitude toward the drug user? The majority of drug users don't engage in crime. Some of them do. So I think that it's certainly a question that we should be studying and we should be looking at and we should understand. But I certainly think that from the standpoint of behaviors that negatively impact on the rest of society, we have criminal sanctions and we have a legitimate right, but drug use per se doesn't. I mean, that's my drug policy sort of self-talking. So I would wonder what others think about that. That's a huge question about whether drug use per se or drug users are criminals.
I think I just want to, I have to jump in. I don't think there's necessarily a direct link. Now, if you're using drugs, therefore you commit crimes. And I think there's no, at least locally, I don't see any study that we have that would make the direct link. I think the concern is that these are the cases that we often hear about. So it's a very skewed population that we're hearing about. And I think if you look at the prison population, and almost half of them, yes, are there for drug-related offenses, but half are there for use and possession charges, for nonviolent crimes. And they shouldn't be there. Now you have people who are there for use, charged for use. What are they doing there? If they are people who are dependent and have related concerns and problems, they will not be helped in jail. They should be somewhere else. So I just want to make sure that we don't make that quick jump where a person is using drugs, therefore it will lead to crime. There's no evidence for that, no.
For me, it brings to mind the usual notion that when we have programs that try to support people who use drugs, either to reduce harm or to eventually help them stop using drugs, is that we're condoning drug use. I hear the same argument when we distribute condoms for sexual and reproductive health, that when we distribute condoms, we condone promiscuity. I keep seeing all these links. From one point, we jump to another without actually seeing a clear link between them, or whether there are, as Ines said, studies to show a direct link. And maybe even if there isn't, we're making assumptions, and that's what makes it dangerous. Supporting a person who's using drugs to reduce harm doesn't mean we're supporting a habit that causes harm. It just means that it might be, I think what we need to start thinking about is, we've been imprisoning drug users for the longest time, but it hasn't actually reduced the incidence of drug use. Maybe we need to start thinking about what else can we do other than arresting them and imprisoning them. There must be other ways of going about it without pushing the community further, because if all we're doing is arresting them, we're actually making them more creative in terms of hiding from us, because we keep going after them. So we're actually pushing them to be more creative in hiding the habit and hiding the community. Why not try to make programs or develop programs wherein, as the doctor was saying earlier, and that's what really strikes me, and my takeaway from this is that if you actually have a program that works, you don't have to look for them. They will come out and seek your service. That's also what we're learning from the HIV work that we do. When we criminalize communities, it's more expensive because it's harder to reach those communities, and they continue to inadvertently spread the disease. But if we are more open and we are more inclusive, we're approaching this from people's perspectives and their rights, then we do not have to spend so much looking for them because they will come out and seek our services.
Doctor, I'm not bothered, but I'm just really trying to wrap my head around it. That's probably the reason why I'm joining the workshop tomorrow.
Great.
But you know, two things. Probably, you know, this just a few insights for now. This will probably work maybe in Portugal or in Amsterdam, but you know, probably from now we can start with advocacy. If we do like maybe this is from the context of treatment. If we do, let's say we implement that wet house, you know, not only are the guys running it will probably get into trouble with the law, but the guys that we're trying to help. So that's one thing. And then the other thing is, in the last part of your presentation, we got to the point of setting goals. And you know, from the context of treatment, there's usually two people that we see. One, they know they have a problem and the goal is for them to stop. The other one is, how do I manage my using? So, you know, more or less we get into a catch-22 here. Setting that goal on how do we manage using on an institutionalized basis, we get into trouble right away. On the law,
what kind of trouble?
Well, just in the law itself, you know, you get trouble with the law with using probably 10 times of the week to just using once. So that's one. Second is, how do we actually, probably maybe just a short answer from you, how do we deliver this managing the using? You know, if that's one of the goals, when do you actually gain traction to get to that one? You know, probably like you working in the trenches, from experience, you know, before they actually get into some sort of that ambivalence, and with this approach, I don't think we're actually even getting away from being pragmatic to just staying in that ambivalence. So anyway, this is just a few insights, Doctor, on this one. And again, like what I said, I'm just really trying to wrap my head around it.
Yeah, I'm not sure that I understood the essence of your question, but what it makes me think about is every illicit drug user is ambivalent about their drug use. Just by virtue of the fact that they have to engage in something that could get them incarcerated. So that the question is always, why are you engaging in this very risky behavior, whether it's risky because of the legal consequences, or risky because of the health consequences, or because of the stigma consequences, right? So what this framework does, this therapeutic framework, is it creates a space to invite people in to have somebody who can have that conversation with them.
Like what I said, Doctor, from the context of treatment, like what I said, we see two people. One part are those with their goals of abstinence. The other part is with people trying to probably find a way to manage their using. They still want to use, you know, they probably have that ambivalence there, and that's the reason. Yeah. But then, you know, my question is, and this can probably be answered by you tomorrow, I don't know, but how do you deliver that for them to be able to manage their using? What are the interventions for that one?
Oh, to help them manage their using.
Yes, that's the second group that we see all the time. You know, their goal is, once we get that therapeutic trust, going through your circle, we get to the point that, you know, my goal is I want to be able to use once in a while. I want to be able to manage and this and that. Yeah. And I'm probably ambivalent about quitting altogether. Now, how do you deliver that? What are the interventions?
Well, that we could spend a lot of time in the next 2 days talking about that. One of the ways that I think about that is part of what we're doing is we're trying to support people in developing their ideal relationship to using. That's a radical idea, and it's challenging. What is your ideal relationship to substances? I could ask everybody in this room that question because we're all substance users. We use coffee, we use sugar, we use cigarettes. Some of us use alcohol, some of us use marijuana, some of us use prescription drugs, some of us use illicit drugs. So we are a group of substance users. So we're all continually considering what is our ideal relationship to substances. In what ways do they help us, and in what ways do they hurt us? So if we can identify the ways in which they hurt us and develop positive goals to minimizing or reducing or taking that negative consequence out, and then we can develop strategies for how to work toward those goals. So for some people, the ideal relationship to these substances is abstinence. And we can support people in coming to that through this process. For others, it's moderate, occasional, controlled. And there are a whole set of different tactics and strategies we might call substance use management techniques that we can explore with people. Being mindful, measuring your drinks, charting your drinks, becoming very clear about when it has a negative impact. So developing the ability to become, to assess your substance use in an ongoing way. Being open with others so that you have partners if you go out to a party and you want to be safe. Having a strategy, a game plan, thinking through risk and how do you minimize risk. There are lots of different strategies that can be employed. That's a taste. Yes. For an alcoholic, there's no way he can manage his drinking. This is a very complicated one. What is an alcoholic? The fact that you have not been able to manage doesn't mean that you can't learn to manage. You may choose, or from your own experience, decide, I can't manage it, and choose to stop. Does that make you an alcoholic? We have this presumption about what alcoholism is, the disease of alcoholism. But I can tell you that some people who have very severe histories with alcohol that I know have been able to very successfully learn to moderate their drinking. I also have patients who have had relatively insignificant problems with alcohol who have chosen to stop because in really taking a close look at their drinking, the occasional night of excess was so bad that they chose to stop, and it wasn't worth the work to. So I've actually, I move away from the idea that somebody per se can or can't, and move more in pragmatically to how can I help somebody determine for themselves if moderation is a reasonable or viable outcome for them or not. And I don't know the answer to that. I see my job is to help people answer that question for themselves.
Hi. Good afternoon. Thank you for validating that abstinence is not the only solution. This is actually, by the way,
May I? I'm a clinical, hi, Dr. Tatarsky.
Hi, how are you?
I'm a clinical psychologist. I'm Epi Gochanko. I have my own practice. I would like to address the earlier concerns. As a clinical psychologist based here in the Philippines, people, I think, one way or another will find a way to get out of a tight spot. When somebody asks you, teach me how to address my drug use, or my alcohol use. Teach me how to change that. That actually, for me, is a trap to you. Okay? And if you try to answer that question, then that person, in my experience, will try to make everything that you say to them wrong. And that's how it's been in practice. I have one case where a woman came to me and she binges, as you have explained earlier. Binging is different from alcoholism. She comes to me because she binges. When she goes home, she blacks out. Her car is like about 30 degrees from where the road is. Her credit cards and her license get lost, and then in the morning she doesn't remember what happened. And she does this every week. So she asked me, what should I do? I said, well, I don't know what you have to do at this point in time, but I would like to know more about you. So we do talk about her, and we learned that she has a problem with her husband. She fell in love with somebody. She has a problem with her family. And of course, again, trauma is involved. We talked about that, we resolved all the issues. After 6 months, she stopped binging. She drinks socially, but does not anymore black out, and she's okay. She manages it on her own without me telling her what to do.
So I love the case. Thank you for
You're
that.
welcome, doctor.
There are two things that your case illustrates to me. One is the issue of authority.
Of a what? I'm sorry.
Authority.
Authority, yes.
That is, that when we set ourselves up as the authority,
correct,
and we are going to tell you what you can do, what you should do,
yes,
it often sets up a dynamic with the patient where the
yes,
patient can't accept what we offer,
yes,
and have to rebel.
Correct.
So that's one of the problems with traditional authoritarian treatment.
Correct.
Whether it's AA-based, TC-based, CBT-based.
That's
Once
right.
we're in the position of saying, I know what you should do,
yes,
and I know your problem, and I'll tell you what you should do. It puts the patient in the position of having two choices. Submit to the authority, which doesn't feel very good to most of us. Masochistic people like that. But even masochistic people then, you know, it can generate a rebellious move. So there's submit or rebel. So what I prefer to take is a position in between where I'm interested in helping you to figure out what strategies and what approach best suit you.
Correct.
I can offer some ideas.
Right.
Here are some possibilities to try on. I don't really know what's going to be useful to you, right? So that's one thing. But the other thing is, maybe this gets at the question of substance use management. There's the techniques, the strategies, and we have loads of them. But there's also the fact that if the impulse to excess, the addictive impulse, is actually being driven by complex forces within the person, we need to create a space to get inside of that. There was a case of Mary that it's a very quick case, simple case illustration, but I have loads and loads and loads of these cases. This is a very successful young attorney. She was in her 30s, very well put together, well dressed, very smart. And she came in to see me because she described a pattern of binging on alcohol every night when she came home. She would walk in the door after work, begin drinking beer until she passed out at night. So it doesn't always happen like this, but in the 4th session, I said to her, I wonder if you can take me into that moment, if you can share with me what comes up for you in the moment when you walk in the door and you feel like having that drink. You know, and she stopped and she said, well, there's a kind of a feeling in my chest. There's an anxiety. And I said, and I wonder if you can identify with the part of yourself that wants that drink. This is what I call unwrapping the urge. Urge surfing, sit with the urge. look into the urge, unwrap it. And she stopped for a minute, and then she looked startled, and she said, why, it's the 4-year-old girl, little girl that I once was, that was kicked down the stairs by my dad whenever he came home angry, drunk. He would literally kick her down the stairs. And so she said, so I would go run into my bedroom and hide under the clothing in my closet, hoping he wouldn't find me. This memory just came out in the 4th session. And she said, it's like I come home and I feel racked with anxiety as if my dad's going to beat me, and I start drinking. It's the same kind of impulse. So then we did this whole bit of work on that trauma. So substance use management skills, we could say, are the cognitive behavioral strategies that can be very valuable. But what they may highlight is that as much as we work on cognitive behavioral strategies, this part of me that wants to get drunk overwhelms me. And if we don't get inside of it, and we just call it the disease, that's my disease talking and I shouldn't listen to it, it actually keeps it alive, as opposed to inviting the impulse into the room so that we can unwrap it and discover, you know, the parts of the self that are living in that impulse and recover them. It's another way to think about recovery. We're recovering lost, traumatized, dissociated parts of the self.
Our specialty is MI, even schema, including schema, and maybe a portion of TA that you just mentioned.
So the schema would also be
Schema,
looking at
yes,
parts.
and then probably a little of what you just mentioned now of TA, with that the adult child and all of these things, together with probably also MI, rolling with the resistance, as you've seen in the circle, which is probably inviting the ambivalence. All of this intervention, doctor, like what I said, I'm just really trying to wrap my head around it to the point when we start doing this treatment planning with the, and that's probably the reason why you place the assessment later on in the circle. Because as our approach, we start doing the treatment planning with the client. But from experience, it's the traction. When do we start having the traction? From experience, it's kind of a bit of a long term. It works, you know, as another example, you know, that's a success story, and we've been seeing the success story. It's at the bottom line, the way I see it right now, it's almost like with the intervention together with strategies, probably integrating these strategies for you know, to address the addiction. Again, this is from the context of treatment. I don't know if that's the case here, doctor.
Okay. Good afternoon, Dr. Tarsky. I'm Nenet Ortega. I am a walking pharmacy. It's just a joke. Actually, first, I'm a walking pharmacy. I would like to thank you for coming over, for providing us with a deeper understanding of the different concepts about drug use or substance abuse, or the so-called harm reduction. And also thank you to NoBox Philippines. If it were not for you, hindi namin makikita si Dr. Andrew. Now, what I wanted to say is that your question was if I am disturbed or if anyone among us is disturbed. I am disturbed every time I hear the word abstinence. But I am wondering if you will be coming over the next time and looking forward to seeing more of the different government agencies who are involved in this kind of issue. Like, for instance, the legislative body, the ones who make the policies and the law, and then at the same time, the Department of Health, because you were saying earlier that we have to look at harm reduction within the health perspective. And thank you for the Dangerous Drugs Board, they are here as well. Now, what am I going to take home in terms of the message? First of all, we have to look within our own homes on the preventive side, along the use of drugs. And then secondly, I am also looking forward that we here as a community, we can work along together as a community, utilizing the different principles of harm reduction and engaging the different government offices and agencies that would help us come up with a strategy on how we will be able to implement a local context of harm reduction. Because I have seen in most of your presentation, you have the methadone treatment, but we are using a different kind of substance or drugs locally. So the ones that you are using abroad is not, I think, at the moment, and I hope they will not engage in a different kinds of or sets of drugs, may not be able to work here. Maybe eventually in the future, when the operational research is done, that would be able to guide the Philippines in terms of developing a model that would work for our context. And maybe with the help of Dr. Tatarsky. Thank you.
Thank you. By the way, some of the physicians and psychiatrists that we work with have worked successfully to use prescribed amphetamines as part of the treatment plan for methamphetamine, which I think is your shabu, it's a potentially controversial practice, but when you have a patient who's motivated for treatment, who you're working with collaboratively, substituting a prescribed amphetamine for street amphetamine is certainly a step in the right direction. And then if you can begin to work to step down the amphetamine use while you're addressing all the co-occurring issues, that has been very successful with some of our patients.
Hi.
Who are you?
I'm your wife.
This is she's actually Dr. Wendy Miller, a psychologist that collaborates with our center and has many areas of expertise.
So I had a thought in response to the woman who said, I'd like to try drugs to sort of see what it's about. And I thought that was such an interesting question. And what it made me think about, though, you would get some info about that, no doubt, but it made me think that it is putting the experience in the drug rather than in the fit between the person's inner world and the drug. And so, in fact, you can't get that experience unless you had exactly the same vulnerabilities, right? Because many, many people try drugs, often in youth, and just lose interest, right? It's that fit where it does something for your particular points of pain that make it such an amazing hook. And it's not about just trying the drug. So that's how I was, that piece about fit is so important.
That's a wonderful response. I mean, that's why I like to have her around, because she's very good. But what it makes me think of is, just to expand on that, is that drugs have different effects with different people, and they have different effects at different dosages. So we can't just be thinking about drug and a particular effect, as you're saying, but really look at the nuances of how a person's using, the amounts, the frequency, the route of administration, and the particular fit with who they are as individuals, and the meaning it has even in their social environment. Drugs have social meaning as well as physiological effect. In a particular subculture, smoking shabu confers a kind of status, and that adds to the positive effect of the drug, aside from the physiological impact. So it's very complex. So anybody who's sitting with something that they'd like to say but they feel kind of shy, maybe just want to share your experience, because we're probably winding down the time of the day. It's been a wonderful day for me.
Good afternoon. I'm Edgar Bante from the Dangerous Drugs Board. But may I just say that I'm not representing the Dangerous Drugs Board here. Depends kagad, ano? But really, I was telling Bai, you know, before the lawmakers enacted the law, probably they should have heard your lecture. It's just too bad that you came in late. But anyway, I was telling Bai that still we can do something to change some provisions of the law so that it's going to be made effective and responsive to the situation. And it's just too bad that during the first time that harm reduction was introduced, there was only emphasis on needle, syringe, and drug substitution. Not the whole package of showing what the benefit of the whole harm reduction program can do. That's why when you tell the lawmakers about harm reduction, their reaction is, again, even without hearing all the explanation, it's already negative. Because, for example, one lawmaker was saying that there are people who need some health services, and you're not able to give them. I am talking about needle syringe. No? And here, somebody's violating the law, and you're providing them free needles. While those who are not violating the law, needing of services, you cannot attend to them. So, in that case, they are against this. And when it was first presented, no offense meant to those who initially present this, they did not mention about how they're going to attend to the drug side of the problem. They only presented it to address the HIV side, but they did not mention anything about how to address the drug side. That's why there was a mention about the operations research. Modesty aside, the two of us, Dr. Benji and I, are the ones pushing in the board on the adoption of the operations research study so that we can get evidence from the Philippines. Because whenever we present evidence that the one you're citing, they always say, that's true in other countries, but not in the Philippine setting. That's why we said, then why don't we allow the operations research so that we can gather evidence from our own place, no? It's just too bad that there are some of those who are really, I don't know if they understood really what harm reduction is. Instead of trying to have an open mind and allow this to be implemented, even on a study basis, they shut down the activity by saying that this is providing more harm than good. But anyway, Bai here is always telling me to continue doing your thing, and we hope you become successful. And in fact, they're also doing something about how the lawmakers can understand better. I'm not saying that they're really very, low in intelligence that they cannot understand. But we were suggesting that probably the lawmakers can also be invited to this forum, like this. Because I think, to tell you frankly, Dr. Tatarsky, my background is, I'm a police officer before. I used to run after those who are, but right now, I am doing a different thing. I'd rather talk to somebody, to a would-be criminal, than arrest him later on. But the thing is, we cannot just sort of just let things go as they are happening. No? Really, there should be an intervention that would really address the situation. I just want to comment on the lady saying that probably we should not be incarcerating those who are caught using or caught in possession. But somehow there is connection about what they're doing. For example, I was telling my seatmate here that if I am a drug user and I just produce the drug that I'm going to use, probably there's no harm. But if I'm a drug user and I am buying drugs from whoever, then I'm giving him the opportunity to earn money and probably to influence a larger part of the community that can eventually, result into something like, for example, situations in other countries where the drug syndicates are dictating on how to run the government. how to run the system of justice, how to run the system of politics. No? That's why we cannot just dismiss that, if you don't arrest drug user, you arrest the drug peddlers. It's very difficult to differentiate the two because, again, the drug users are the one giving the opportunity for drug traders to earn money and probably to influence. No? So anyway, I am very glad that we were invited here. But again, I want to emphasize that our presence here with Dr. Benji is not to spy on what they're doing, but rather to probably enlighten us more so that we can have some arguments, better arguments, to convince those who do not yet believe to believe. Thank you very much.
Well, as a visitor and an outside observer, I would be willing to bet that the community is very, very happy to have you on the Dangerous Drugs Board. Number one. And it's very nice to have an opportunity to meet you and hear what you have to say. And secondly, I'm going to be here until Monday. So if you could round up a group of lawmakers, I would love to have a chance to meet with them and share some of these ideas. But the other thing is, on the last point you made, generally speaking, the drug peddlers that are selling to one another are really also people with drug problems who are selling just to survive. And I think it's important to distinguish between low-level drug peddlers who themselves are struggling with all of these issues and the cartels and the criminal groups that are really bringing the damage into communities. So just something to consider. Yes, we have a comment over here.
Thank you very much for giving us this opportunity, Dr. Tatarsky. You know what I was bothered about when they were talking. I'm happy to know that there are government agencies here. Tomorrow I'll be in the Senate of the Philippines. I'll be talking with senators tomorrow. You want me to make an appointment with them? No. You want me to invite them tomorrow?
Well, I
no,
absolutely.
No, I am going there because I am working on the nursing law amendments. We are making amendments to reform the nursing, conditions in the Philippines, the exports of nurses, etc. But I'm going back to my previous assumption that we have to work on the Filipino family. We have to strengthen the values of the Filipino family. We should teach them how to bond, how to care for their children. And I'm going to tell these lawmakers, and I will be with a congresswoman because I'm the consultant of one congresswoman. I'll be with her tomorrow. So I will work on Congress, and I'm the consultant of one of them. So I will try to stake a claim that the government should act on this problem. I am an officer of the Anti-Drug Abuse Foundation of Quezon City. And we have been, for your information, sirs and ma'ams, from the Department of Health, we have been supporting them with, sports, this ping pong, basketball, etc. And they are based at Payatas. It used to be under the vice mayor, now the mayor. I don't know what's happening now because we withdrew our support because we don't get any moral support from the government at that time. So I hope anyway, I'm afraid I will be, hindi, malibel ako kung pupunta sa newspaper ito. But anyway, my husband is a good lawyer, so he can defend me. Yeah. I would like to, I'd like to work on the strengthening of the family. We had a daycare center. We invite parents. We give them some lectures about how to care for the children. We had a clinic, no? But we had an independent practice, so we disbanded. But as a private person, I'm working with my inner wheel clubs of Quezon City. I'm working with my Zonta club as vice president. We give lectures on anti-drug abuse because it is my my compassion to work on this. I have 5 children, but thank God.
Okay, thank you, ma'am. We
That's
have
it.
one last question to raise. Yes, comment or question, yes.
Good evening. I'm Virgilin Palamata, one of the guidance counselor at the Constellation College, Caloocan. However, I would like to pursue a graduate studies on clinical psychology. So, to get out of the legal context questions, I would just like to ask questions, just like the other theories such as Freud and Adler and Carl Rogers. They have the inclinations to their theories based on their personal experiences. So if I may ask, is there a personal experience on your part regarding the harm reduction psychotherapy? But if you would just like to answer my question. Or if it's too personal, it's okay if you don't like to answer.
Well, I grew up in the United States in the '60s, and I grew up in a subculture of artists and musicians and those kinds of people in New York in the '50s and the '60s. And so there were many people around me that were drug users. And in fact, one memory comes in 1969. I went away for my summer vacation, and I came back to discover that many of my friends were using heroin. And some of those people went on to develop serious problems. And so, you know, I saw a lot of drug use firsthand, personal, and saw the human side of it. And then as I got into the field as a professional, what I was taught was a treatment approach that seemed to really dehumanize, that didn't seem to really empathize with that human complexity. And so I think that my early experience growing up around drug use had a very big impact on me, and then informed my later, you know, observations of what was wrong with the system. So that's a personal side of it. Yeah. Thanks for asking that question.
Thank you very much for answering.
All right, so before we close the forum, again, we would like to remind you that your questions can also be sent in through Twitter via hashtag AskNoBox at NoBoxT, via SMS 0906-577-3986. We also have our remaining event activities would be tomorrow and Wednesday. That's the integrative harm reduction psychotherapy at the Seda Hotel. And then we also have Harm Reduction 101 on Friday. And on Saturday, we also have a question and answer with Dr. Tatarsky. That would be at NoBox, at the NoBox Lounge there. So, in behalf of NoBox Transitions, we would like to thank everyone who have helped us grace this forum. And of course, we would like to thank Dr. Andrew Tatarsky for his help. Yes, and we are also opening our book signing. So everyone who has the book can have Dr. Tatarsky's signature.
On behalf of NoBox, I would want to say thank you, as Grace had said, to Dr. Tatarsky for being here, for initiating this conversation, and I hope we do continue this conversation. Let's not let it stop here. The whole week he's still going to be here, so we can continue on that conversation. And even after he has left, NoBox lines are open, NoBox doors are open, and I think even me personally, I'm like energized by the response of everyone here. And I think what you said also about being agents of change, it's not enough to say, kasi our law is like this, Our law is like this. I mean, we at a certain point, we have to stop complaining and actually do something about it. And I think we all here can do something about it, but if we work together. Like NoBox is here, use us. because we can't do it alone. But together, I think there's such tremendous thing that we can do. We can make tremendous impact. Because at the end of the day, it's really about, we're discussing this all here, and at the end of the day, it's about saving real people's lives. Right now, as we speak, people are using and might be in danger. One in Cebu, that's a very, very clear example. You stop something, right now, how many people are injecting and putting themselves at risk? So the problem is very, very real. So please, let's work together. This is an appeal. So thank you very much, everyone. And thank you so much, Dr. Tatarsky.